this week on the BackTable podcast.
I think it's just so important to really, figure out what the patient wants and what sort of their swallowing and eating rituals look like before, this impairment or sickness or illness happen, because sometimes we try to fix things that weren't broken to begin with, or we have these ideas of what is important in our culture and maybe totally different to a different family. So really, I think that's paramount and first and foremost. Obviously, getting the swallow studies is so important as well. You guys are doctors, you know the importance of instrumentation. And it's just so tough when we hear, administrators saying, well, we don't want to pay for those tests, or can't you just tell if they're aspirating? No, you can't. There's no explanation other than no. So as much as you could, help us and advocate to get those tests done, it is really what's best for the patient.
Hello, everyone, and welcome to the BackTable ENT podcast, where we discuss all things ENT. We bring you the best and brightest in our field with the hope that you can take something from our show to your practice.
Protect your most valuable asset, the skill and ability to practice your medical specialty. 1 out of 3 individuals become disabled during their career. Be prepared by establishing a specialty-specific disability insurance policy from the experts at DI4MDs. They represent all the major disability insurance companies that provide individual policies for physicians. Special discounts are available for all physicians, residents, and the military. Whether you have no coverage, or to compare and improve your current coverage, or take advantage of the new higher monthly benefit, contact them today at www.di4mds.com. Again, that's www.di4mds.com, or call them at 888-934-4637. Again, that's 888-934-4637.
My name is Gopi Shah, and I'm a pediatric ENT, and I'm here with my lovely, amazing colleague, podcast co-host, and my dearest friend, Dr. Ashley Agan.
Hello, Gopi. How are you this morning?
I'm happy. I'm always excited to be here on this podcast because we have amazing guests. And in the last couple of days, it's our national, the COSM meeting. And so it's been nice to run into old friends, colleagues, mentors, and just more amazing people.
Absolutely. I know. I felt the same way after getting to kind of run into some old friends and have a conference in person again. That was cool, just to have that energy and be able to see people. Was a lot of fun.
Yeah.
So can I introduce our guest today?
Oh, yes.
Teresa Richard is a board-certified specialist in swallowing and swallowing disorders and medical speech and language pathologist in Jacksonville, Florida. She's founder and CEO of Medical SLP Collective and Med SLP Education, and has her own podcast, Swallow Your Pride podcast. She is the author of the book, So You're Having Trouble Swallowing. She previously owned Mobile Dysphagia Diagnostics, which provided mobile fees studies to thousands of patients in over 100 skilled nursing facilities across 4 states. Welcome to the show, Teresa.
Thank you. Thank you for having me.
First, tell us a little bit about yourself and your background, your practice.
Yeah. So went to grad school to be a speech pathologist. Always just wanted to get into a helping profession, really. I have a brother with cerebral palsy who used augmentative communication devices growing up. And I just was always frustrated with the lack of access to the communication technologies and things like that. So that's really what sparked my interest in speech pathology to begin with. Went to graduate school, thought I was going to come out working with kids, did my fellowship with kids, and realized that I did not want to work with kids. And decided to take another fellowship in the nursing homes. And oddly enough, I ended up just loving it. I did not think I would ever work with swallowing disorders, but I just found the work to be so impactful. I loved connecting with, residents in the skilled nursing facility that have had these amazing long lives and have done these amazing things, and now all of a sudden find themselves not being able to swallow. It's something that's such a huge part of our quality of life and just means so much to so many people. And then to all of a sudden not be able to do it, I just found the work to be really, really impactful. So I worked in skilled nursing for about 5-6 years. And at the time, we had a company come in and do mobile fees procedures, which is fiberoptic endoscopic evaluation of swallowing. And it's within speech pathologist scope of practice to do it to evaluate swallowing. I know you guys use the endoscope for a bajillion other things, but we just use it as a camera to view the swallow. So I decided I really love that diagnostic portion. I felt like a lot of what we did was really a puzzle and just, being able to give these patients answers as to why they can't swallow or what they might be able to modify or what they might be able to have at Thanksgiving dinner. So I really just love that diagnostic portion. And so I ended up starting a mobile fees company when I was living in Las Vegas, Nevada. So I had that for a few years. And then I had a son who was born with a very rare chromosomal abnormality. And of course, he had to have a baby fees when he was a newborn. So things hit really close to home there. It was really interesting because we did not have a speech pathologist in the NICU. He was in the NICU for 15 days and was not eating. And they really just had no answers for us. They just said, oh, he'll figure it out. He'll figure it out. And I just knew you don't just figure it out. So that really, set my mama heart into overdrive and really inspired the book that I ended up writing as well, because I had all these patients, all this experience with patients at the end of life. And now I'm working with my own son, learning how to eat at the beginning of life. So hit me with anything. I've got experience across all ages. So.
I think you hit you said it perfectly. It's a puzzle in swallowing. I don't think obviously my practice is pediatric, but the more I see, kids that have trouble swallowing, dysphagia, whether they're NPO to certain foods, it is so complicated.
It is.
It is. The more, it's not just a little, okay, just do this. Like it's really hard to kind of understand why. And then, how do we use the tools that we have and what's going to benefit, whatnot. And like you said, it's a major quality of life, as well as, health with weight gain and things like that, to how we connect with our families and our, people around us. So it's such a hard and really requires a team approach.
Yeah. So what does your practice look like now?
Yeah. So I worked in mobile fees. Like I said, moved a few times, worked across a few states. I ended up selling my mobile fees company last year. And the reason was because in the meantime, I realized while I was out in the field that even so many people in our own profession, even so many other speech pathologists didn't realize what we were capable of, just didn't have the tool set, didn't have the skill set. You learn very little about swallowing in graduate school. And I think selfishly, I believe it's the most impactful. I just don't think, as you mentioned, Gopi, there's nutrition and there's quality of life. There's so many things that require eating. So I sort of went on this crusade of just education, and I started blogging, and the blog sort of took off. And from there, that's when I started podcasting and started the Swallow Your Pride podcast. And from there, speech pathologists kept reaching out, wanting more and more and more knowledge. So I started a continuing education membership site called the SLP Collective. And once COVID hit, I had another baby, went on maternity leave, and then COVID hit. And sort of when I went to go back to work after maternity leave, COVID was rearing, and there was such more of a need for me to be involved with the continuing education, because speech pathologists were just, wondering, what do we do? How do we help all these patients? How do we help these patients coming off the vent? Can we do swallow studies on COVID positive patients? What do the precautions look like? So I sort of found myself just on the back end of the education aspect of it. So, which was not where I ever thought I would be. But I love it. I love being able to do the digging in the background and help deliver, information to people that are on the front lines, people that are in the field. Like this is what the research says. This is what other, facilities are doing. These are the procedures that other facilities have come up with. So it's been really, really rewarding to be on that end of it.
Yeah. And I don't want to skip over your podcast. Her podcast is like number 10, number 11. Like it's in the top of Apple podcasts for medicine. So Teresa's a big deal.
Yeah. Well, thank you.
This is a pretty amazing podcast that is reaching a lot of people. So bravo.
Thank you. Thank you.
And the title is amazing. I love it. Swallow Your Pride. It's amazing. Yeah. It's a great title. And the book title is great too. I mean, it's so, anyways.
I think another thing with speech therapists or speech language pathologists, there's a bit of a branding issue when you're talking to patients about, I'm sending you to the speech therapist for swallowing,
Yeah. Yeah.
I find myself always having to kind of say like, well, but that is, they're also experts in that because they're like, I don't need a speech therapist. I can talk fine.
Yeah. And I think it's one thing where you're kind of like, okay, this is what we're going to do. And then honestly, from my side of it, sometimes I don't always really know or understand or maybe have the exposure to all the details and different things that the speech language pathologist does and offers. And really, since I've been in my practice, I have to say, coming out of training, definitely didn't really get it. And the more and more I see patients, the more my poor speech pathologist here, Ashley Brown, she's like our swallow expert for our pediatric ENT patients. I send her stuff like messages all the time, questions all the time, because it's such a hard patient population. It really is.
Yeah, it's tough. And it's interesting because, like I said, we don't get much training on it in grad school. There's a few graduate programs that have really intensive medical backgrounds, but on the other, most of us have just been out there working, learning by experience, reading the research ourselves, attending different conferences. So it's sort of the wild, wild west. And it just was something I became so passionate about that I just dove headfirst into all the research, and I just wanted to know more about this area because, like I said, I just think it's so impactful and just, such a quality of life. But on the flip side, and I don't want to talk about the negative because I'm a half glass full person all the time, but we have a lot of speech pathologists in the field that mean well and that think they're doing the right things with their patients and might be doing some exercises that we once thought were good that we have no research or even effective. And same with swallow studies. There's people think it's pass fail, and it's not. They can tell us a ton of information. So really just what I do is I just want people to be able to have this information at their fingertips so that they can help their patients the best that they can. Because what I don't want is a patient to go to a speech pathologist, say they have swallowing trouble, and just not get the answers or not get guidance that they needed.
Yeah, I think it's so true that eating is such a core part of how we socialize and, part of who we are. When patients can't eat anymore, it's a big deal.
Whether it's your baby, your grandparent, your spouse, your friend. I mean, it's
and having that, anxiety or embarrassment about going out to eat with people, just, all over the place. So let's get into, talking about dysphagia. And Gopi and I had, when we were talking about it, we were thinking, well, first we probably need to just set the stage with some terminology, because even Gopi and I, use different terms when talking about barium swallow, modified barium swallow, video fluoroscopy, fees. There's all these different terms, that are technically swallow studies, different ways to look at the swallow, but, you can call them different things depending on, who you are, or where you are. Tell us about that.
It's interesting. The modified barium swallow study has been around a while. Gosh, I think maybe in the 70s, I believe, is when Dr. Jerry Logeman basically, I don't want to say invented it, but pretty much is the one that came up with that procedure. And that sort of was the gold standard for the longest time. And that is an X-ray. It's done from the side, so you're able to see the swallow on an X-ray. Dr. Susan Langmore in the 90s basically invented FEES, which is fiberoptic endoscopic evaluation of swallowing. It's a top-down view, obviously, with the endoscope. So each has their pros and cons. What I like to say is which test is best. And to me, it's the one you can actually get. And I think we all know limitations of working in hospitals, working in doctors' offices. Are you rural? Are you, where are you located? Sometimes the logistics of getting the ideal test just do not happen, especially with, if you're in the NICU or working in skilled nursing. So for me, ideally, I just always say the test you can get is the best. We can obviously get into the pros and cons of some. What I do want to talk about also is the difference between the modified barium swallow study and a barium swallow that GI does. Because so many times, this is something that I just want to educate every intake coordinator and every scheduler at a hospital. I even went through it with my own son. We were trying to get one scheduled. And she's like, "Are you sure you don't want the barium swallow?" And I was like, "No, I know what test I need." And so that's just so frustrating. And I hate that they're coined so similarly. But video fluoroscopy is sort of the new name now, or video swallow, basically, because it's done with fluoro. So a lot of people still do call it the modified barium swallow study, but video fluoroscopy is now sort of the new term to use.
Okay. And that's probably better because then it takes the barium name out of it. So you're less likely to confuse barium swallow and modify barium swallow.
Correct.
Okay. Good to know.
Yeah.
And when you're thinking, let's say I think you make a great point. It's which one can you get? But let's say you have a patient that will tolerate both. Which one do you like for what problems or which one tells you what?
Yeah. So I am in my perfect world, I would always do a fees first. And I say that because I think there's so much information that it can give us right off the bat. It's obviously it's a real live picture. So you're viewing the larynx, you're viewing the vocal folds. You can see the esophageal inlet. So there's things that you can see right off the bat that we might be able to say, ooh, this is something that just needs to go right to ENT, or this just needs to go right to GI. I think sometimes we get ahead of ourselves in trying to intervene and trying to fix things therapeutically that might need surgical or medical intervention. With the fees specifically, a lot of times, I mean, we just see so much effects of reflux or even allergies, things like that, so that's when we got to send them off to you guys to just get them, medically or surgically stable first. So that's why I'm such a big believer in fees as sort of the primary tool, especially because it is so easy for us to use all the time. It doesn't involve all the logistics of radiology, but things that you see on fees, we assess especially a lot of secretions. A lot of these patients that are trachs and vents, secretions are a huge thing. So we can sort of tell if they have secretion management or not. We are able to view different foods and liquids and textures that we can actually see them on the fees. We assess for different laryngeal, pharyngeal anatomy and sensory deficits. You can view if there's focal paralysis or paresis. You can check out why there might be different voice changes. And it especially can be really beneficial for like pre or post head and neck cancer surgery as well. So those are sort of the top things that you would really want to go to fees first. But like I said, I'm really biased and I admit that. And I always think that fees is the best tool to use first. But a lot of people that don't have experience with fees and still believe the video fluoroscopy is the gold standard will absolutely take the information we can get from that any day. But video fluoroscopy is superior when looking at esophageal issues because we're able to see basically from the nose down to the stomach if the radiologist allows us to scan down that far and get a view of the lower esophagus as well. You do get a much better image of the oral phase of the swallow on video fluoroscopy because it's on the side. So you can tell if there's chewing, rotary chew, if they're able to basically bolus transit, you're able to tell if the tongue's moving in the right direction, all that stuff. So yeah, those are pretty much the biggest differences about when you would use one or the other, but a lot of it comes down to logistics, if I'm being honest. So,
and for your fees, you're using like dyed foods, like, you do thin liquids, thick liquids, puree, a cookie or something like that, and looking for residue and seeing how it passes?
Yep. I just was trained to use green food coloring. So that's what I use. It colors the water easier. It's very easy to see on the contrast versus sort of the pinkish reddish, features that we see. There's been a lot of research that's been done actually lately with white food coloring. So like white cake frosting dye. And what they found is that actually the white is able to be visualized much better than any of the others when it is going down into the trachea. So it's been interesting to tell, are patients aspirating more than we think they are with this white dye versus any other color. So that's been some interesting findings that have really come to light in the last few years that I know a lot of the researchers are looking into.
I wonder if it's, when something goes through the cords, it's going to be shadowed and it's kind of dark down there. And then, wow, but I would have never thought about that.
I think it's so fascinating. Like I said, I've been doing fees I started in 2013. It's almost 10 years now. And just to watch the technology improve as rapidly as it has, I just think of like the original endoscope that I had, sort of the grainy structures. And now it's like this HD, you can see it's crazy.
Yeah, that distal chip is nice.
Yeah, it's beautiful.
And then so when you were just going to the mobile fees practice, what were you taking with you? Did you also have a tower and a screen? Were you recording these? Is it mostly just what you see in your eye?
Yeah. So you guys are lucky enough that you get the big, huge, beautiful towers, but obviously that's not ideal for mobile. So a few companies make these mobile units, which is essentially just a laptop or like a tablet, and an endoscope just plugs in via USB. So it does have, recording capabilities. It's, actual medical technology software on there. So I literally would just carry like a little briefcase with the laptop with the endoscope, the USB cord in that. And then I also carried a bag that had, the cleaning solution, alcohol swabs, everything that we need for the high-level disinfectant to do that, as well as the green dyes. I would bring in, depending on which state, some states allow you to bring foods into the nursing home, some do not. So sometimes I had to use what they had there, but I like to make it really individual for the patient, to be honest. We do have protocols in that, you should start with thin liquids up to thickened liquids and then different food textures. But I really like to see what the patient likes. And that's something something that is my, high horse. I will talk till the cows come home about patient preference and what's important to the patient and the family. And we can trial all these different textures, but if it's nothing that they even care to eat, then how do we transfer those results over into what they really want to do at home? So that's something I really would try to do too, especially in a skilled nursing setting, or if we know they're going home soon, what foods are you going to eat all the time? If I tell you to eat this, are you actually going to eat it? So I like these, and that I try to make it very individual. And I had this one woman that all she cared to eat was M&Ms. And so we did the study with M&Ms, and she aspirated all the M&Ms, but we at least had that information. So yeah.
Oh, man.
So in your evaluation, I guess we'll just kind of like take it from the top, as patients coming in to see you and, or you're going to see them if it's mobile, what's the history taking look like? What's important? What are important things to be asking? And I guess, another thing from our side of it, what important things do we need to be asking too before we're sending patients your way?
Yeah. It's sort of all the above, just a normal case history. What surgical interventions have they had? What is their medical history look like? Medications is a huge thing too. As I'm sure you guys know, medications can impact the swallow greatly. So sometimes it's just nothing that we can do therapeutically as much as just recommending, sending them back to the physician and getting a change in their medications.
Are there particular medications that are common ones that stand out that affect the swallow?
There's especially a lot of muscle relaxers. If you think of the swallow, it's about 40 different muscles that make the swallow happen. So sometimes if you have patients on Ativan or something like that, or another form of muscle relaxant, and they complain that they can't swallow, that's something to consider. So that's sort of when we work closely with the psychologists in the facility too, to see, what can we do to sort of relax this patient or ease the behaviors that they're having, but also still allow them to be able to eat by mouth, because it can be very dangerous. There's many, cases of patients aspirating or choking while on a muscle relaxant. So
that makes sense.
Yeah. The other thing is the Parkinson's medication. So levodopa, the timing of those, we've seen it's night and day if you see a patient or a Parkinson's patient before or after they've had their medication. It can be just the most uncoordinated swallow ever, but you give them the medication and it's all of a sudden beautiful. So that's one thing. As soon as you see a patient with Parkinson's, and if you know that they're on, a levodopa regimen, make sure that they're eating about a half an hour after they've been given that medication. So that's something that's very common to find that to be an easy solution in nursing
When you do
homes.
your evaluation, do you have them time the medication so that you get the best possible test?
Ideally. Yep. Because sometimes you just can't get anything, if, so we try to, and also just educate them too, and just say, hey, without this medication, you're going to be calling me in again, because it's going to be really ugly. The patient's going to be struggling, so do you want to do it before the medication or after? There's obviously, pros and cons to both sides, but you want obviously the patient to be eating and swallowing as effectively and safely as possible.
Do you find that medications that have dry mouth as a side effect, do those, because I tend to blame that a lot, because I'm like, well, you just don't have enough saliva and, your mouth's too dry that you can't, is that, do you see that?
Absolutely. Yeah. Absolutely. And I think, one thing too is those lemon swabs. A lot of people tend in the nursing homes or in the hospitals to tell people to use those to sort of do oral care, which no, we should just be using a toothbrush and toothpaste for oral care. But the lemon swabs too dry out the mucosa immensely. So then people don't have enough saliva to be able to produce a swallow. So usually I just tell everyone, please throw out all the lemon glycerin swabs. And yeah, so if you're a producer of those, please don't come after me, but figure out a way to keep the mouths wetter.
Yeah, that's a good question, Ash. And when I think about it in the pizza world, Teresa, do you ever see like some of the in terms of secretion, right? Secretion management is a big thing. And every once in a while, a patient might be on something like glycopyrrolate or a scopolamine patch to help dry it up a bit. Do you ever find that that dysphagia or something can be a side effect from that medication as well?
Absolutely. Absolutely. I know the scopolamine patches are such a necessary evil sometimes. I know we see patients almost, for lack of a better term, drowning in their own secretion. So they'll be recommended one of those patches, but then on the flip side, it dries them out so much that they can barely swallow. So, that's something that I think is so important for the speech pathologists and the doctors to work so closely together to, weigh the pros and cons of that. Because I've seen the scopolamine patches help tremendously, but then I've also seen them, tip back the other way and cause all these unwanted side effects. So when I do see that patch, I usually will bring it up and just, probe a little bit more, why did you start why did you start using this patch? Have you noticed anything different since? And it's sometimes patients are like, it's been a lifesaver. And other times they're like, I'm so dry. So that's when, we'll go back to the doctor and just try to brainstorm it. Is there something else we can do? Or,
It's such a hard balance.
It is.
Because of secretion management, aspiration, are they eating and drinking that little bit, how much benefit? It's such a tough balance with so many different factors.
Right. Because obviously we don't want them aspirating all their own secretions too. So if it's helping in that aspect, then that's wonderful.
But if there's amazing pleasure in that, 15 cc's of whatever 4 times a day, like that's a little bit of joy that if I can bring my kid or my, relative, that's still huge too.
Moving on kind of through your visit, and you've asked your, questions and kind of gathered your history. What's next? I guess, it might depend on where you are, right? If you're at bedside or if you're in your office.
In the ICU.
Take us through that.
If the patient obviously can communicate, and if they can tell you, or if you have access to a family member too, I like to sort of hear what does a normal meal look like? What foods do they typically like to eat? What are some cultural considerations to think of too? Because sometimes we'll make recommendations to, slow a patient down or things like that, but it's the way they've been eating for a million years. And a lot of patients with developmental disabilities, especially, kids with Down syndrome, they eat in a very, for lack of a better term, it looks ugly under a swallow study. You would just say, this is a mess, but for them, it's completely functional. And they may have never had, an aspiration event. They may have never had a pneumonia. So it's really important to collect that data ahead of time, because what we've seen in our field is sort of just being too conservative by saying, oh my goodness, this is not functional. We need to alter the diet, or we need to thicken the liquids. And then you can send the patient to all these behaviors because you've just modified things that they don't understand or for what reason, and decrease the quality of life. So I like to take a lot of steps back and just see what is normal, what is considered functional for them, because we're just learning now that the range of normal is much, much, much bigger than we once thought. So if we can get that information from a patient or a family member, that's something that's really so crucial, because we don't want to be thickening patients' liquids, without knowing for sure that that's absolutely what they need to be on. So
I'm glad you brought up pneumonia, because I think, when I was a junior resident, I kind of thought if a patient coughs when they eat, then they should be NPO. Like if they, aspiration equals don't eat, right? But now it's like, well, if you're not getting pneumonia, then, maybe you have a, strong cough, and, if you aspirate a little bit, you can get it out, and we don't have to just keep you from eating, right? Which is probably the worst thing you can do for a patient that's maybe having some issues. Because maybe, I don't know, you don't use it, you lose it, and maybe things get worse. I don't know.
Yeah, I was going to say those little minor modifications might be 20,000 steps back. I feel like. Tell us about what you and your experience.
So we know a lot more about sort of the pillars of pneumonia at this point now. We know that you have to have a lesser functioning immune system. So if you have a well-functioning immune system, your chances of getting pneumonia are a lot less. Another thing to consider is the oral microbiome. What does that look like? If you have healthy oral care, if you're brushing your teeth, toothpaste, mouthwash, you're killing all that oral bacteria. So the chances of it, even if it does go into the lungs and you aspirate, the chances of it turning into pneumonia are really slim. And, part of the healthy immune system, we say, are they a walkie-talkie? Are they walking and talking? Because if they're up and functional and moving, then obviously they're going to have a stronger immune system. So those are things to consider too before we even look at, okay, so is this patient aspirating? Okay, yes, they are, but how is their immune system? How is their oral care? These are the things to consider. If those things are poor, then we know that they're at a much higher chance of aspirating. My son, for one, is what we call a functional aspirator. So he does aspirate. We've seen it on a swallow study. He's never had pneumonia. Obviously, he's got severe special needs. So we are religious about brushing his teeth constantly. He doesn't walk on his own. He uses a gait trainer, but we make sure to get him up in it a few times a day, things like that, to keep walking, keep his immune system functioning. So there's a lot to consider with that. And then on the flip side, if we do see that patients have recurrent pneumonia or they are in for aspiration pneumonia, what causes it? So then we try to go backwards and figure out that puzzle piece. Is it because of a poor immune system, or do they have a true dysphagia that's, that they are aspirating all the time? So, we've talked about this as just a really complex mechanism, but Dr. Susan Langmore, who's one of the researchers that created the FEES procedure that I do, actually wrote a seminal paper, I believe back in, I think she wrote 2 iterations of it, 1998 and 2002, on the predictors of aspiration pneumonia. And dysphagia actually was number 7. So things like dependent for oral care, dependent for feeding, the number of medications, smoking, multiple medical diagnoses, number of decayed teeth, and suctioning are all before dysphagia. So these things are all really important to consider as well. And like I said, we, for not just lack of knowing better, just assumed when you aspirate, it turned into pneumonia, right? But there's so many other factors that we have to consider before we just say, oh, you're going to get pneumonia if you aspirate. Here's some thickened liquids, good luck.
Can you tell us a little bit about the different patient populations that you see and those nuances, whether it's the, stroke patient, the head neck cancer patient, and I think you'd mentioned some of your prolonged intubation patients. How does that affect?
Very much so. And I think that's what's interesting, because it causes a lot of conflict in our field, because we do have SLPs that work with, like I said, these walkie-talkies, these, patients that may have had a stroke. So they may have some impaired muscle functioning. They may have a paralyzed vocal fold. But other than that, we're able to rehab the swallow back to it being functional. On the flip side, you might have a patient that's in the ICU or a patient that has head and neck cancer. We're going to be much more conservative with those patients, especially the transplant population, the lung transplant population. Those we have to be extremely conservative with. So, a lot of times within our own field, you'll say, oh, I never use thickened liquids, or I use thickened liquids all the time. And we sort of have to back up and say, okay, what setting are you working with? What patient population are you working with? Because that makes the world of difference. Working in home health is going to be a lot less conservative because the patient is home. They are stable. Whereas obviously seeing patients in the ICU that may just be post-COVID coming off the vent, we're going to be a little more conservative with those. So we work with a lot of different patient populations in the NICU with, developmental disabilities. So there's a lot of populations that we work with, and it's just something that I do in my continuing education, is just make sure that what we're doing in the patient populations that we're serving, we're really knowledgeable in those conditions and how those specifically impact the swallow. And we're not just treating with this, blanket approach to everything.
Yeah, that's a great point. Even in our own practices, I mean, how many times, Ash, have you changed up either your workup or your management options, whether it's something, ear fluid is ear fluid or whatever it is, but because of the actual, when you tease out the clinical history, it's a whole different, right?
There's a lot. There's always nuances depending on the patient and, what you're trying to treat, what are your expected outcomes and that sort of thing, for sure.
Yeah.
Can you walk us through some of the different assessments? So for example, what does a bedside swallow evaluation look like in the ICU versus, the kind of workup you would do when you're in a clinic or, seeing patients outpatient?
Yeah. So pretty much going to do the case history, do a clinical swallow examination, do a cranial nerve exam. Those are obviously pretty important for us to, figure out is what we're working with. Neurological, what are the impairments there? The clinical swallowing exam, you're going to probably start with the Yale swallow protocol or just a 3-ounce water challenge. These are actually, nurses can even do these, can be a nursing screen. So they take 3 ounces of water And if the patient is able to chug the entire thing without stopping, without taking a breath, they are considered passed. So it means they don't have to go on for further swallowing evaluations. I will say the caveat with that is we are finding some different patient populations that the test isn't as reliable as we thought. So sort of back to the drawing board with that, but that at least gives us a good foundation, because if, like I said, if they had to stop, if they had to cough, if they had to do anything, it should go to an automatic instrumental assessment. So FEES or video fluoroscopy. Yeah, depending on what the patient looks like, we might trial some foods and some liquids with them. Obviously, if they're in the ICU, we're not going to go, there right away. But if they are coming to the clinic, we'll try some different textures, see how they do. Things that are also important is different, like coughing. It's a huge thing. If they're able to cough, then that's a good thing, right? They're able to protect their airway. So those are things that we assess as well.
And I would think that drinking a cup of water, that challenge is going to be more sensitive for picking up someone who might be at risk for aspiration, because when you drink water, it's going to go down faster. But you may not catch people who are going to have issues with, solids or thicker foods.
Right.
We have patients who, are like, oh, I have trouble swallowing bread or things like that, right?
Yep. So that's obviously, the nuance of the test, right? So, that's part of teasing that out a little bit more and trialing the different food textures. There's a lot that we do, and there's sort of a movement away from doing just that, from just watching your patients eat as an assessment, to doing a lot of these other tools. We have a lot more rating scales and things like that now that help us get a lot more information about our patients than just sort of, like you said, sitting and watching them eat bread and seeing if they can do it or not,
Well, and I would imagine, what about, do you ever have to, like, if you're in the ICU or even maybe routinely, do you ever have to have like a suction available? Do you have to tell RT or the nurse, like, hey, I might need extra, do you ever need extra set of hands or, right? Because most of the time before speech is involved, you think that the patient's ready for that, right?
Yes. Yeah. So that's very hospital specific, and the ICUs all sort of have their own practice patterns of how they do that. A big thing that we're sort of starting to overturn is this 24-hour rule. It used to be that when a patient came off the vent, they had to wait 24 hours to eat or drink. There wasn't really research to support that. It just was sort of like this guideline that was put into place and nobody really knew why. So, depending on the patient's status and respiratory status, all that stuff, it's getting to be a lot sooner. That being said, suctioning is something that speech pathologists can do if they're deemed competent by a respiratory therapist or whatever the competencies in that hospital are. So I worked in one long-term acute care hospital that I was competent to do the suctioning. I worked in another one that they didn't allow us to do them. RT had to do it. So we all play
I'm
nice
just going to put the
sandbox.
scope in the nose.
I know. Like, I work with some wonderful respiratory therapists that I'm like, can you please come help me?
Yeah.
So luckily I've worked with some phenomenal RTs, and it is what it is. But yeah, I know there's definitely been a big push to get speech pathologists to have this competency to be able to manage the patients, on their own. We do, speaking valve trials, and actually they're called speaking valves, but they're actually also called speaking and swallowing valves. So doing those trials are important for us to be able to suction if we need to, inflate, deflate the cuff, all that stuff, as long as we've been deemed competent by the facility, is something that we're able to do.
Yeah. Speaking of, for example, patients who have a trach, or maybe patients who have an NG tube or a Dobhoff tube, there's other things that are in the upper air digestive tract that are usually not there. And, just thinking intuitively, it seems like those are going to affect your swallow.
Yes.
How do you take that into account when you're assessing someone, because you assume, okay, maybe some of this dysfunction is because that's there. But we're also trying to kind of move you along and, pass the patient to be able to start eating more. What is that? How does that play into your evaluation?
Yeah, and I think that's the necessary evil of the NG tubes, right? I used to love feesing patients with an NG tube because you would just pass the scope right along next to the NG tube and you had, very clear entry there. But on the flip side, how many NG tubes have you seen that have been twisted and wrapped around and in horrible, positioning? And that gives you your answer right, right there. A lot of it depends on how long they've had the NG tube as well. We all know they should not be in there long. It's a temporary fix, but sometimes these patients get sent from the nursing homes with them, or they get just lost in the shuffle and they have them for an extended period of time. And swallowing, absolutely, as you mentioned, is a use it or lose it type thing. And the best cure for a swallowing problem is swallowing. So if this is in there and it is impeding, what we try to do is, can we pull it to get some exercises done? Is there alternate means of nutrition? Do they really truly need the NG tube? So there's a lot to evaluate here, because we absolutely have seen a lot of patients that their swallowing is impaired because of the NG tube. And once that's pulled, they are able to regain functioning pretty rapidly.
What are your thoughts on, like a G tube, do you feel like it's better to move forward and, maybe do that earlier just to get the NG out of the way and get them, able to practice more eating from, normally, and then just supplement nutrition with the G tube? Or do you feel like, it's probably patient specific, but
definitely
what do you
patient
think?
specific. And I would say, sort of the camp that I'm in is we want to avoid a G tube at all costs.
Okay.
So we usually are begging to allow the doctors to give us a few days to rehab the swallow. Usually, a lot of times it comes head to head on like a Friday night, right? And they just want to, stick a peg in the patient. It's like, please just give me till Monday to try to get some swallowing going, to see if we can really get this patient going. Because what's so hard is it's tough to rehab a patient that has a G tube. Because if you think about it, the G tube's in the stomach. It's telling the patient that they're fed, that they're getting nutrition. It signals to the brain, you don't need food, you're not hungry. So going in to do swallowing therapy on a patient with a PEG, they're usually like, oh, I'm not hungry, I don't want to eat, I feel really full, I have this tube in. And it's sort of this mental gymnastics that you have to tell them, like, I know your brain's telling you that, but I'm telling you we need to try to swallow, because that's the only way that it's going to, we're going to get rid of that tube. So it's a big school of thought that we want to try to prolong the G tube as long as humanly possible. Obviously, we don't want to starve our patients or, have them, lose nutrition status or anything like that. But if there's something that can be done in the meantime, that's really what we try to fight for.
Yeah, I find that we have a lot of infants that are home with a drop-off tube for months, depending on their overall clinical history, prognosis. Our pediatric GI and, SLPs are amazing when it comes to outpatient management of that. And, again, I don't do adults anymore, but I did find that dispoing, right? You had to figure out how to get the patient out of the hospital, and having an NG or a drop-off as enteral access always limited that as well. And so it's hard to, is it more common to dispo adults now with NG and drop-off, whether it's skilled nursing, LTAC home, or do you find that that's not as much of an issue anymore?
I would say it really depends. I've worked at some facilities that absolutely, and I've worked in others that really try to avoid that as much as possible. So I think it really just depends on the interdisciplinary team there, because I think, we all want them to be, as stable nutrition-wise as possible, but we also don't want to make it an even harder rehab road to begin with. So it stinks, because obviously now there's the big push for decreasing length of stay in the hospital. So we want to get patients out as quick as possible. But then the people on the rehab end are like, please don't, keep them one more day, or, stabilize them a little bit more. So it's really tough to balance. And I think that's just where it comes down to the interdisciplinary team getting together and setting sort of these guidelines and these competencies in place. Like, okay, this is what we're going to do with this patient, or this is what this really looks like. And the SLP fighting for one more day to, maybe get that NG tube pulled and get some swallowing started, or, working with RT to see, how is respiratory stable, things like that. So I just think it really comes down to obviously patient specific, but really the interdisciplinary team working together to figure out what's the best long-term plan for this patient.
Yeah. And I feel like rehab criteria is so stringent. I mean, they really are strong, or kind of firm, maybe is a better word, about when they feel like the patient's ready. And I think that's a great thing, because they want it to be successful, right? You don't want a bunch of back and forth, and you want the goals of the rehab to be met as the patient's ready. So you have to appreciate that.
But it's also frustrating to think that you're making clinical decisions based on the ability to go to rehab, right? That you're making a decision to put in a
100%
PEG,
Yeah, absolutely.
Just for dispo. So it's tough. But it's the healthcare environment that we live in. So
I know.
Make it work, right?
I know.
We take care of a lot of, head and neck cancer patients, which is a unique patient population in itself when it comes to swallowing, because a lot of times there's been an alteration in the, oral cavity, pharynx, larynx, there's been surgery or radiation, all these types of changes. And so I think, those patients in particular are a unique group and probably need to start working with an SLP, from the beginning. I don't know, what's your experience with that?
Yeah. So a lot of my really close colleagues, that's really all they do. They work in these head and neck, cancer centers. And that's really all that they see is they see patients prophylactically, get them started on swallowing exercises, before the surgery. So I think it's so important for them there's a lot of research, obviously, that getting started with exercises prophylactically is so important. I've worked with a few laryngectomy patients. There was one place that I worked that we got a lot of laryngectomy patients, and I haven't seen any since, but really, really fascinating to see patients swallow that have a laryngectomy.
Mm-hmm.
It's pretty amazing what the body can actually do. But yeah, I think one thing about our field that is so cool is that if you can specialize, it's really super rewarding to learn everything about that specific patient population. And like I said, some of my best friends work in these really specialized cancer centers, and that's all that they see. And they know about the different chemo and radiations and the impact that can have, and, the fibrosis and everything that all the side effects that it can create. And so, I have I feel so passionately for them and the work that they do.
Yeah. And I think there's some a misunderstanding that a patient with a laryngectomy, should be able to swallow no problem because they can't aspirate anymore, right? They've had complete separation of their upper digestive tract, But because I remember attendings in residency being like, there's nowhere else for it to go. They'll eat fine. It's just going to you put it in the mouth, it's got to go down. But it's, it's a big surgery that changes all of that anatomy. And there can be a lot of, it can take time to get to where you can be
fistulas. There can be all sorts of complications. Yeah. And I think that is a tough part. Obviously we want the surgery to go so smooth. It's great when you have a laryngectomy patient that can eat without any troubles, but the reality is, there's different pressures that are now changed, and the swallowing mechanism really is just based on pressures. So there's a lot to consider, and why, they should have swallow studies pre and post surgery, and really pretty often actually throughout the whole head and neck cancer process.
Yeah, I was going to say it's probably something that's almost lifetime. I mean, if you think about the head and neck cancer patient, if they've had primary surgery, whether it's a laryngectomy to whatever free flap to having a trach, then maybe getting decannulated, then having had potentially chemo, radiation, those long-term effects. I mean, the way all the different, I guess, changes, whether it's anatomy and side effects, are going to affect over time. And so I can only imagine, your SLP is going to be your right-hand person to kind of help you gain all that back, whether it's speaking or swallowing in those patients. But
as far as when we're sending patients to our SLP colleagues, what can I be doing to kind of help tee up that visit? Are there things that we can have patients, start working on, or is it good to get some sort of swallow study before they see you? Do you like to have that video fluoroscopy swallow eval when during that first visit when you're evaluating a patient, or is it better to just, I guess it depends on if the SLP has fees available to them, right? But what can we be doing just to help set patients up, other than reiterating that speech language pathologists do treat dysphagia?
I love this question, Ashley. Thank you. I think the fact that you're even asking this just means so much to a lot of SLPs. But I think really the most important thing, a lot of times we get a lot of patients without any sort of paper trail whatsoever. And we have no idea where they came from, what they've been through, what medical intervention they've had, what surgical intervention they've had, what pharmacological intervention they've had. So really just a solid, thorough case history is worth its weight in gold.
Yeah.
And to us, if we can get a swallow study ahead of time, also that means so much, because that at least gives us a starting point to say, oh, wow, it looks like they functionally improved, or it looks like they're, going downhill. It gives us a good baseline. So in a perfect world, that would be wonderful, but really, truly just a solid case history. And I think just being accessible, we work so as part of a big interdisciplinary team, and sometimes there's just a lot of holes in the story. And, could we just call the ENT and get some more information? Or could we call the pulmonologist and get some more information? I think that's usually, I for lack of a better term, hate our healthcare system right now, and that it's so hard to get a hold of each other, right? You know, you have to call like the 0 line at the hospital and track down everybody. And I just wish there was a way for medical professionals to like have, you know, backdoor communication to, you know, hey, I've got a question about this patient, you know, what can you tell me? So I think just being accessible, or, you know, letting the SLP know, hey, my name's Ashley, here's the number of my office, you know, let me know how I can help. That's really just so helpful, because a lot of times we're just piecing together what we have with a patient that's been dropped at our doorstep, for lack of a better term. And we're left to do the solo study with the information that we have in front of us with a very limited amount of time. And then you sort of send them back off into the world like, you know, did I answer all their questions? Was that the right answer? So a really solid case history is everything.
Well, yeah. Well, and that, you know, without that communication, it's so interesting that you could be like, as the ENT, I have one idea, right, of what I think is going on.
Right.
They have an assessment or an evaluation. It's completely different. And then I'm like, you know, I'm obviously missing something. And so that dialogue is so beneficial for the patient. And it's easy when you're on the same Epic system or whatnot. But having to reach out and it can definitely make it real painful for everybody, for the patients too, because they're just like, can y'all just talk to each other? And the answer should be yes, right?
Right. I even went through that with my own son. He was sent to a rehab center, and speech pathologist evaluated him, and you know, she called, didn't know I was a speech pathologist, and just gave me this whole report of like, you know, he can't do this. We're going to modify his diet to this. He can't do this. And I was like, yeah, no crap, lady. Like that's his functional. And I was so angry because I was like, had they just reached out to me to begin with, I could have given them all this information. But instead, you know, it seemed just like a whole waste of her time and medical resources to go through and do this whole thing, and had really nothing to do with how he presents on a daily basis. So obviously that could be a whole nother episode, is interdisciplinary communication.
We definitely, it's eye-opening when you're a patient, when you are on the other side of healthcare. You know, it really changes the way you think about, you know, your interactions with patients when you kind of have to walk in those steps.
Sounds horrible and inhumane. It's like a dog chip. You want to like put a chip in them with like all of their information, like so that anybody can read it. Like,
especially patients that have a complex medical history. Yeah, for sure.
Do y'all do a lot of adult neuromuscular electrical stimulation, the NMES or vital stim is what I think people like to call it?
Yeah, it's interesting because it's controversial.
I was going to say, is it in vogue, out of vogue?
It depends. It depends on the patient population. It depends on the device that you're looking for. So neuromuscular electrical stimulation is a wonderful tool. What depends is the device that you use and the parameters that you use, because there are some that are approved by the FDA and there are some that are not. And the answer is no, you cannot just pick up any device, slap electrodes on someone's swallow and start zapping them and hope that they can swallow, because you can send them into laryngeal spasms and all that. And we don't want to be on the end of that. So short answer, there's absolutely a place for it. It's just very device specific. And, you know, I don't want to get into the nitty gritty of that right now, but there's some devices that I don't ever want to use because their parameters can be dangerous and are not FDA approved. And then there's others that are. So the big thing is that some of the devices really only are for sensory stim, and there's others that actually have been shown on FEES and video fluoroscopy that they get actual motor movement of the swallowing muscles as well. So really ideal for, you know, sort of those post-stroke patients, really helping to sort of bring those muscles and nerves back to life after having a stroke. And I've seen some really, really cool data with it. So it's a wonderful tool. It's definitely something we should have in our toolbox, but I just have to put that caveat disclaimer out there that you can't just pick up any device and slap electrodes on a patient's neck.
Yeah. Is it like a TENS unit?
It is, but what I believe TENS is just sensory, right? Okay. Whereas I believe neuromuscular electrical stimulation is actually supposed to cause a motor movement as well.
Interesting. Well, and when we're sending patients to you, what can we do as far as setting expectations? Because sometimes I'll talk to patients, you know, and say, you know, maybe you may only have to see them one time, and maybe they'll give you some exercises you can do on your own. You know, they may want you to, you know, come back and see them a few times. You know, it depends on the evaluation. That's kind of generally what I tend to tell patients. But what other things do we say?
It's really patient specific, to be honest. Like a lot of patients will a lot of patients want to improve rapidly. They want to be able to chew the finest, chewiest steak ever. Or some really just don't care. So
Right.
the prognosis and the length of treatment and the intensity of treatment really depends on their goals of care. And I think that's somewhere that we sort of get ourselves in trouble because we just assume, oh, well, let me just give you, put you on a puree diet, you'll be on your way. And the patient gets home and they're like, what the heck? Like, no, I want a burger. I want a steak. Or on the flip side, you have somebody that maybe doesn't have dentures or just wants to eat ice cream for the rest of their life. They don't care about eating a steak. So it really, truly depends. So I think, getting that information out in the case history and when you're doing the swallow study, we have a lot of wonderful tools available to us. Technology is beautiful in what we're able to do now. We have a lot of different biofeedback tools that we can use. We do have some really intense dysphagia exercise programs too. So there's a few different programs that, it's hours of swallowing therapy for, 3 to 4 weeks on end. And we've seen some patients go from NPO back to eating again in a month on these protocols. So really just depends on how much the patient wants to put into it and really what they want their quality of life to be. And, if they want to eat ice cream for the rest of their lives and they're fine with that, then, we'll just do 1 or 2 sessions and tell them, do this, don't do this, come back and see me if you change your mind. Or, we will do some really intense rehab.
Can you do some of it virtually? Are y'all able to do some?
Yeah. And the beauty of COVID, if there's such a thing, is that was one thing that right when COVID first hit, I believe Medicare allowed us to do teletherapy for dysphagia, which they didn't used to allow. And then I believe when they were going to overturn the regs, but they actually kept it that we still can do it. So I think that's been a game changer, especially for a lot of these rural, if you live 3 hours away from a major medical center, come in for your swallow study. But then if we can just do treatment, over Zoom or something, it's a huge, huge benefit to the patient. So short answer, there's still obviously a lot of nuances with the different insurance companies and what they'll pay for and, dealing with technology with patients. But I believe for the most part, it's a huge, huge, huge blessing. I know I actually have a friend, Gopi, in Texas, and she just got some teletherapy regs overturned for working with babies. So she's doing a whole seminar called like Fed with Telemed, just really helping
awesome.
these feeding
to
kids,
bring
helping the parents.
Right. Other
Right.
childcare, it's a lot.
Yeah, I think virtual is here to stay in some form or another, for sure.
And I think it's beautiful in this aspect, if we can just do a lot of consulting and things like that and have them only come in when they really, truly need to.
Well, and they're eating at home. So to be able to do therapy at home in their natural setting and where they're going to be, also those adjustments, modifications, questions, hopefully only maximizes their therapy.
And we do have, like I said, the technology is just wild what we're able to do now. And there's a lot of different biofeedback tools that, the patients are able to place on themselves. And then we're able to, read the muscle activation and things like that on our end. So that's really cool.
One more thing before we let you go. There's a patient group that I always struggle with. The patient comes in and the chief complaint is dysphagia. They're having some trouble swallowing. They have a normal flexible scope exam. They are not losing weight, seem perfectly healthy and normal. Otherwise, get a modified barium swallow. It's also normal. And they're like, well, doc, why can't I swallow? I really am having trouble swallowing. I'm really not going to let this go. Because you tell them, okay, good thing is everything looks normal. But they're like, no, I'm not normal. What's going on? How do you take care of those patients? Or what do you usually find?
A majority of the time is it's muscle tension dysphagia. And I'm not sure if you guys are familiar with that.
Yeah.
Okay.
Let's talk about that. I feel like I learned that term in the last maybe couple of years from our speech therapists.
Yep. And that's really sort of what we're finding. And I believe there's even more work that came out this year, even spelling it out even more. And a lot of it is just stress. They're seeing it a lot more now after COVID. It's really interesting because it's a lot of just where people are holding their stress and their tension, but it's so bad that the muscles are so inflamed that it's really impairing the swallow. So a lot of it is these vocal exercises, these vocal relaxation techniques. So, speech pathologists work with swallowing and voice. I only do swallowing, but a lot do both, or some just do voice. But that's sort of where I rely on my SLP colleagues that specialize in voice to do these vocal relaxation techniques, which can help to relax the swallow. Something else that, I don't know that it's controversial now, but I did write about it in my book because it comes up enough, is sort of the psychological component too. And patients going for hypnotherapy or therapy, or they may have been through trauma subconsciously long ago. And so there actually is research and there is studies that have shown that, sometimes these patients need this subconscious change in order to be able to swallow if there is nothing that we can see, on an actual swallow study. So,
I mean, it makes sense when you think about, in our GI clinic, there's a GI psychologist. You know what I mean? So your swallow is part of it's all together. It's part of that same. So it makes sense for sure.
Yeah, I think as a medical professional, you want to just be able to see the problem and diagnose it and fix it. And it's not that easy sometimes. And I know some people think that's, woo-woo and isn't the truth, but there is some truth to it. And so I do, I do want patients to know that is something if they're desperate and want to research that a little bit further.
I think in ENT, especially because so much of it is quality of life, right? Some of the problems that we have or see in our patients, whether it's vertigo, feeling, the dizzy, the migraine, the headache, sinus headache patient, or, dysphagia, any little bit that can help the patient move forward, whether you've identified something or not. And many times there's not a necessarily a pathologic reason or surgery or medicine. But if there's some tool, that's always helpful.
Yeah. And I've had patients who bring up stress to me. So, I may be talking to them and say, well, good thing is everything looks normal. We're not finding anything. And like sometimes they'll say, do you think it could be stress? And I'll be like, well, yes, tell me, are you stressed? Like, yeah, actually, let's talk about that. So I think patients are, kind of cluing in on how that mind-body connection works and how, if you are stressed out, sometimes your body doesn't work right.
Sometimes as physicians, especially, I don't think we're always clued into that.
Right. That's not part of our training.
Right.
Yeah.
We're supposed to find that pathologic,
see the problem,
fix it.
Fix the problem.
Yeah. And
I know I've definitely gotten in some arguments with other professionals just in our field about it because I'm just like, there's nothing else to explain, like you said, and then you send a patient off to a psychologist or to further explore it. And they, come back and they're like, that worked. I had to do these exercises or do these different meditation, guided meditation exercises, and it helped. So, I think it's one thing I know from being a mother and dealing with my son's issues, you have to listen to the patient. We know what we know, but we only know what we learned, right? So
yeah. I remember this was probably January when Omicron was surging, and I had like a sore throat and a headache. I swear I thought I had COVID. Got the test. 3 days later, I was fine, and I was like, nope, that's just me, middle age, reflux, 2 kids, and a headache. You know what I mean?
Yeah.
There's nothing wrong. Okay, like.
Yep.
Take a look in the mirror, figure your stuff out. It's not COVID. Go back to work.
Well, I think we could probably go, on and on about this. But yeah, as we round it out, what is there anything that we have, left out as far as, the workup and management of the adult dysphagia patients? Anything you want to leave our listeners with?
I think we pretty much covered it all. I think it's just so important to really figure out what the patient wants and what sort of their swallowing and eating rituals look like before, this impairment or sickness or illness happen, because sometimes we try to fix things that weren't broken to begin with, or we have these ideas of what is important in our culture and maybe totally different to a different family. So really, I think that's paramount and first and foremost. Obviously, getting swallow studies is so important as well. You guys are doctors, the importance of instrumentation, and it's just so tough when we hear, administrators saying, well, we don't want to pay for those tests, or, can't you just tell if they're aspirating? No, you can't. Like, there's no explanation other than no, we don't have x-ray vision. So as much as you could, help us and advocate to get those tests done, it is really what's best for the patient.
Yeah. Awesome. Well, thank you so much for taking the time. And listeners, please check out Teresa on her podcast, Swallow Your Pride, her book, So You're Having Trouble Swallowing. What about, are you on any social media?
I am. I'm mostly on Instagram. Teresa Richard SLP is my name on there.
Cool.
I think I'm on Twitter. Sometimes I'm on Facebook, but Instagram is usually where I am. So
awesome. Check out Teresa, y'all.
Thank you, Teresa. you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ENT on Instagram, LinkedIn, or Twitter. BackTable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team lead is Kieran Gannon, with support from
Caleb Hodson.
And Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Thanks again for listening, and see you next week.